Hello, in this video, we are going to discuss the management of the heart failure. Now, what is the main aims of the treatment in chronic heart failure? Now, you know that there are many causes of the heart failure. Like the heart failure may be because of the decreased contractility. So, if we increase the contractility, we can improve the signs and symptoms of the heart failure. Now you know that in the heart failure, the heart is unable to pump out blood, and that blood accumulates in the ventricles and in the venous circulation, so cause the venous congestion. And you know that when the blood accumulates in the heart, and more blood is coming to the heart, there is increased preload. Okay. Now if we decrease the preload, like if the preload is decreased, less blood will come to the heart, and this will put less pressure on the heart, and in this way the signs and symptoms of the heart failure can improve. uh, Third is the afterload. Now if the heart failure is because of the increased afterload, or if there is a heart failure and if we decrease the afterload, like if we dilate the arterioles, okay, this will decrease the afterload and the heart has to work against less pressure. This also improve the heart sign and symptom, like there will be less oxygen demand for the heart. So in this way we can improve the heart, a failing heart actually. And the fourth is the controlling the cardiac rhythm, or the rate. Now if the heart failure is because of the arrhythmias, and if we control the rate and rhythm of the heart because of the arrhythmias, we can improve a failing heart. And this can be achieved by a combination of the drug treatment or the non-drug treatments. So first we will discuss the drug treatment, then we will discuss the non-drug treatment. Now first of all, we have to generally like manage the patient, like the general lifestyle modification. And you should remember this line, that all patients should monitor weight daily to detect the fluid accumulation. You know that in a failing heart, the fluid accumulate in the heart, like there is a pleural effusion, there is a ascites, edema. So we have to manage the weight of the patient daily. Like if the weight is increasing day by day, it means that the heart severity is increasing day by day, and there is the fluid accumulates. Okay. Now we have to monitor the weight daily. Next is education of the patient is very important, like about the causes and the treatment of the heart, planning to improve the adherence to a management plan. Okay. Now a sodium restriction. Now if the patient with a failing heart take the large amount of the sodium or salt, this will lead to increase more fluid in the body, and we have to decrease the fluid. So this patient should restrict sodium intake. And there is also fluid in the body, okay, like ascites, edema. So fluid restriction is also important. Next is the weight loss, smoking cessation, restrict alcohol use, and exercise programs. Then are the drug treatment. Okay. So heart failure can be systolic or the diastolic. The drugs used in the systolic are the diuretics, ACE inhibitors, beta blockers, spironolactone, digoxin, hydralazine, nitrate, sacubitril, valsartan, and the ICD pacemaker and transplant. While in the diastolic, beta blocker and the diuretics. We will discuss each of these drugs in detail. Okay. Now two slides are very important in the treatment of the congestive heart failure. One is this one, and one slide after this. Now you know that the New York Heart Association has classified the heart failure into four classes. Okay. And each class has a different approach toward treatment. Now what does class 1 says? Class 1 means that the heart failure is mild, like it is not very severe. And if in this case there is no limitation during ordinary activity. Okay. The sign and symptom occurs when a patient do a very vigorous activity, like playing a sport. So in class 1, the treatment option will be lifestyle modification, like the dietary changes, like sodium restriction, fluid restriction, and exercise. And the drugs like the ACE inhibitors or ARBs, ACE inhibitor, ARBs, and also the diuretics, they are almost used in each of these four classes. Okay. So ACE inhibitor, ARBs are diuretics. Remember all classes. Okay, now class 2 are the mild to moderate. Okay, mild to moderate congestive heart failure. Now in this case there is a slight limitation during the ordinary activity, like the sign and symptoms occur during the when you walk to around the street, like the ordinary activities. Okay, and the treatment option will be the lifestyle modification, AS inhibitors, or ARBs, diuretics, beta blockers. We will discuss each of these drugs. Okay, now beta blocker is added in the class 2. Okay, and also diuretics. Class 3, moderate to severe. Now, in this case, there is marked limitation of the normal activities without symptom. And here the symptoms occur while you are dressing or eating. Okay, so with normal activities, there is symptoms occur. And the treatment option for this class will be the lifestyle modification, the AS inhibitors or ARBs, the beta blockers, diuretics, spironolactone, and digoxin are added in moderate to severe heart failure. Remember this, digoxin are used only in class 3 and class 4, not in 1 and 2. Okay, because of the various side effects, they are not commonly used in class 1 and class 2. Okay, they are not actually the first line drugs for the congestive heart failure, or the a combination of the diuretics and the AS inhibitors or ARBs. Okay, these are the first line. What does class 4 say? It is the severe congestive heart failure will be class 4, and the symptoms occur at the rest. And the treatment option will be the AS inhibitor, ARBs, beta blocker, diuretics, ARNIs or MRAs like the spironolactone. Okay, ivabradine or digoxin. And advanced therapies such as the implantable devices or heart transplantation, they are done in a very severe heart failure. Okay, now this slide is also very important. What are the mortality benefits in systolic dysfunction? For MCQs why this is very important. Like AS inhibitors or ARBs decrease the mortality, they improve the mortality. Diuretics does not improve, they only control symptoms, while these drugs improve the mortality of the patient. Same as the beta blockers, the spironolactone or eplerenone, the hydralazine or and nitrate, this combination is used, or the implantable defibrillator, they improve the mortality. Now, first we will discuss the systolic dysfunction management. The first drugs used is the diuretics. The diuretics promote the urinary sodium and water excretion. So actually they decrease the preload. When the preload is decreased, less blood will pump to the heart, and less blood will come into the left ventricle, and the heart has to contract against less blood. So there will be less oxygen used, and this increase the overall uh, symptoms of the heart. They also decrease the pulmonary and systemic venous congestion. They also reduce the afterload and the ventricular volume. So when the afterload is decreased, like there is the arterial dilatation, the afterload will be decreased, and the heart has to work against less pressure, less afterload. This also increase the cardiac output and the overall heart efficiency. And the dose of diuretics needs to be titrated carefully as to avoid the excessive volume depletion, like, and they will cause the decreased cardiac output with hypertension, lethargy, or renal failure. So remember these side effects. So diuretics are recommended for patients with moderate to severe systolic dysfunction, but they are actually used in all classes. Diuretics control only symptoms. As we have already discussed, they do not improve the mortality. Okay, and it is the initial therapy. Remember this initial therapy of congestive heart failure with low ejection fraction often includes a loop diuretics. So loop diuretics in combination with the ACE inhibitors or ARBs, they are the initial drug of choice. Okay, now in diuretics, loop diuretics are very important. They are used in the congestive heart failure. Like most important is the furosemide. Other are the bumetanide or torsemide. The other diuretics include the thiazide-like diuretics, and the drugs here are the metalazone or the chlorothiazide. Okay, and they are used to augment diuresis with the loop diuretics. Next drug is the spironolactone. This is they directly inhibit the effects of the aldosterone. So it is the mineralocorticoid receptor antagonist. And the spironolactone is only prone to effective for the advanced and the serious stages of the congestive heart failure, like we already discussed in, it is used in class 3 and class 4. in moderate to severe congestive heart failure, and they also improve the mortality. The side adverse effects is the hyperkalemia or the gynecomastia. Like you know that the aldosterone retain fluid and salt in the kidney, and they improve or increase the blood volume. So if we inhibit aldosterone, the blood volume or fluid will be decreased and the preload will be decreased. Okay. And next is the eplerenone. Eplerenone is alternative to the spironolactone that inhibits the aldosterone, and it does not have the anti-adrenogenic like effects that lead to gynecomastia. So it does not cut gynecomastia, and eplerenones also lower the mortality, as we have already discussed in that important slide. Next is the angiotensin converting enzyme inhibitors or the ACE inhibitor. This is a very important class of the drugs in congestive heart failure. Like the example here are the enalapril, like remember the pril and at the end lisinopril, captopril. Now they decrease the preload. Actually, the liver synthesis the angiotensinogen, and the kidney synthesis the renin. Renin cause the convert the angiotensinogen into angiotensin 1, and the angiotensin converting enzyme from the lung convert the angiotensin 1 into angiotensin 2, and it is the angiotensin 2 that cause the effects like increase vasoconstriction. So if we inhibit the as angiotensin converting enzyme, these effects will not be occur. Like there will be vasodilation, the aldosterone will not be increased. So the effect of aldosterone, like they retain the fluid, so the fluid and salt will not be retained, and there will be decrease in the blood volume and after in preload. Okay. And there is the vasodilation, so will, and also arteriodilation, so they will decrease the afterload. So sodium and fluid will not be retained. Okay. So decrease the preload, reduces peripheral vasoconstriction. Okay. And this is actually the afterload, not the preload. And the reduces salt and water retention, decrease the preload. Okay. Preventing the activation of the renin angiotensin, we already discussed, improve the motility. Now angiotensin converting enzyme inhibitors, these agents should be given to all patients with systolic dysfunction at the any stage, like they are used in all stages. Okay. Now what are the adverse effects? Like there is symptomatic hypotension because there is a dilatation of the vessels, so there will be hypotension, and there will be impairment of the renal function. Like if there is the hypotension, the kidney will not receive enough blood, so they can cause the pre-renal renal failure. Okay. Increase in serum potassium concentration, like the aldosterone effect will be inhibited, so potassium will be retained. Okay. Normally potassium is excreted by the aldosterone, here it will be retained. The renal function and serum potassium must be monitored. It's very important. Potassium and the renal function must be monitored and should be checked every 1 to 2 weeks after starting the therapy. Now angiotensin receptor blockage or ARBs is the second class. Valsartan, losartan, and candesartan. Remember the sartan at the end. These are the ARBs. ARBs act by blocking the action of angiotensin 2 on the heart, peripheral vascular and the kidney. Its effects is like the ACE inhibitors. Okay, but they are used only when there is these side effects of the ACE inhibitors, like the cough or angioedema. When these are present with the ACE inhibitor, then switch to ARBs. Otherwise, use ACE inhibitors. Okay. Now beta blockers, all the drugs are beta blockers are not beneficial in the congestive heart failure. These drugs like the metoprolol, bisoprolol, and carvedilol, these are used in congestive heart failure. Remember these three drugs. The benefits of beta blockers likely stems from the, like beta blocker have anti-ischemic effect, like they decrease the heart rate. When the heart rate is decreased, the oxygen demand will be decreased, and this can improve a failing heart. There is a decrease in the heart rate leading to decreased oxygen consumption. Anti-arrhythmic effect, like the beta blocker control the heart rate. Okay, so they have also anti-arrhythmic effects, and you know that arrhythmia is the most common cause of death from the congestive heart failure. So the ventricular arrhythmias like ventricular tachycardia and ventricular fibrillation. It is best managed with the beta blockers, and they reduce the mortality. Now Iowa braiding. It is the SA node inhibitor of the funny channel. Funny chain is like present in the SA node, and when they depolarize the SA node, fire and all these contractions occur. Okay. Now, if we inhibit this SA node, the heart rate will be slowed down. So it is used when the heart rate is over 70 beat per minute, or when the beta blocker cannot be used. You know that the beta blocker decreases the heart rate. Now, when the beta blocker is not effective, use this drug. Okay. It is ineffective in patient with atrial fibrillation. Remember those. They no rule in fibrillation, and they decrease only the symptoms. Okay, reduce hospitalization in patient with reduced ejection fraction. So reduce only symptoms. Digoxin. Digoxin can be used to provide. They control the heart rate, and they are used when there is left ventricular dysfunction. Okay, so congestive failure and the atrial fibrillation, they are used here only. In patient with severe heart failure like New York Heart Association classification class 1, class 3 and 4. In moderate to severe congestive heart failure, they are used only in class 3 and 4. Okay. Now reduce the likelihood of the hospitalization for the heart failure. Digoxin has never approved to lower the mortality. So they cannot lower the mortality, they only control the heart rate. Okay, and they have various side effects like they can cause arrhythmias, like they can cause the GI upset. Okay, hydrazine and nitrates. Now they are used only when when the ACE inhibitors or ARBs are contraindicated. They are used only when ACE inhibitors cannot be used. If ACE inhibitors cannot be used, then switch to hydrazine and nitrates. This combination. Okay, so nitrate like the isosorbide dinitrate. These are the venodilators. So when the veins dilate, the blood will not be enough blood will not be coming to the heart, so they reduce the preload. Hydrolyzid on the other hand, they are the arterial dilator. So when the arteries dilate, the heart has to contract against less pressure. Okay, so they reduce the afterload and cause the hypotension. Okay, due to these dilatations, and they improve the mortality. Remember. Now, sacubitril and valsartan, this combination is also important. Angiotensin receptor neprilysin inhibitor like neutral endopeptidase. This enzyme, they break down the BNP we have discussed in the video of the investigation of heart failure. BNP is very important. They elevate in the congestive heart failure. They improve the dilatations of the vessels, and they BNP also improve the net uresis, like they improve the urine output, so they actually decrease the congestion. So this enzyme decrease or break down the BNP. So if we inhibit this enzyme, the BNP level will not be decreased. Okay. So used in patient with the ejection fraction less than 35% with maximally tolerated ACE inhibitors or ARBs. Okay. So if ARBs or ACE inhibitors are not helpful, then use these drugs. They shown to improve the mortality. So mortality is lowered with these drugs. Sacubitril is added only to ARB. Valsartan is in ARB. Okay, so only with ARB. Provide mortality benefit for systolic dysfunction. Amiodarone, this is a potent anti-arrhythmic drug that has little negative inotropic effect, like they decrease the contraction. Valuable in patient with poor left ventricular function, and if the heart failure is because of the atrial arrhythmias or the ventricular arrhythmias, use these drugs. This is important. Calcium channel blocker play no role in the treatment of congestive heart failure. Remember this. Now, what are the non-pharmacological treatments? So there are various devices like this one and this one. They are used in the treatment of the congestive heart failure when the drugs are not helpful. Then these devices are used. One is the implantable cardiac defibrillator. They are implanted in the chest wall, and these devices are indicated in patient with the symptomatic ventricular arrhythmia. So when in the heart failure, so if the patient is have rhythmic episodes, these devices are implanted and they defibrillate the heart when the arrhythmias occur. So they automatically defibrillate the heart whenever arrhythmias occur. So used in ischemic cardiomyopathy, and remember this, when the ejection fraction is below 35%, it means that your heart is failing, and they are used in, okay, so 35%, remember. Improve prognosis and survival. So implantable devices improve the mortality. Resynchronization devices are the biventricular pacemaker. Pacemaker is used when your heart is like unable to contract properly, like there is bradycardia or there is the intraventricular conduction delay and there is prolonged depolarization. So when the heart is unable to contract properly, and if there is uncoordinated left ventricular contraction problem, you use the pacemaker. And ejection fraction under 35%, or the white QRS complex is above 120, or three small squares. So then use pacemaker. This is associated with improved symptoms and survival. Third is the coronary revascularization. Now, if any of the vessel of the heart is stenosed, okay, the coronary artery is stenosed, they can cause ischemia and congestive heart failure. So this can also be an option. Coronary revascularization, like the PCI, like the stenting, or the bypass surgery. Okay, and the last option we have is the cardiac transplantation. Okay, and when maximal medical therapy like these and possibly the biventricular pacemaker fail to control the symptoms of the congestive heart failure, then the only alternative is to seek the cardiac transplantation. And the conventional heart transplantation is contraindicated in patients with the pulmonary vascular disease. Like if there is pulmonary hypertension and you transplant the heart to death patient, this patient will suffer again from the right ventricular heart failure. So not beneficial here. Okay. Now diastolic dysfunction. Congestive heart failure with preserved ejection fraction. Here the ejection fraction is preserved, like the ejection fraction is normal. There is a problem of dilatation. There is less space in the ventricle, okay, for the blood. So any drug that improve the contractility or improve the stroke volume, cardiac output will not be helpful here. So the only option we have left is the beta blockers. Okay, beta blocker reduce the heart rate. When the heart rate is reduced, there will be enough time for the left ventricle to fill with blood. Okay, now they can be beneficial. And diuretics, they control the symptoms of the fluid overload. In the diastolic heart failure, there is fluid overload, and for the fluid overload we use loop diuretics like the furosemide. Digoxin and spironolactone should not be used. Remember, this should not be used. And ACE inhibitors or ARBs have unclear benefit in diastolic dysfunction. So this was all about the management of the heart failure. Thank you. See you in the next video.